November 4th, 2025. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. You're tuning in to a live stream of spine surgery. This patient is a veteran of war. He's from the Vietnam War, as a matter of fact. And he underwent a fusion on his neck for injuries to the discs. The fusion was done over 20 years ago, but over the years he's developed adjacent segment disease with the discs above and below the fusion degenerating and becoming symptomatic with herniations that are pinching his spinal cord and nerves. You could see those on the MRI scan that Henry has attached to the video, so you guys could see it in the opening slide, I think. And long story short, we discussed treatment options. He's already had a fusion at C4-5. Can you show us that fusion, Jordan? You see the bones are fused together, and what's important to note here is that the disc is missing, so the joint between the bones is missing because it's fused. He did a fusion without a metal plate or screws, and look at the angulation of the fusion. He has what's called kyphosis. It's a reverse curve of the spine in the neck. You're supposed to have a curve backwards. He has a curve forward. That forward curve has created problems and accelerated the adjacent segment disease. So basically the fusion wasn't done right, as many spinal fusions are not done right out there. And as a result, there's more problems now for the patient to deal with. Now he has to have surgery again. He did not want another fusion. We offered it to him. He wanted the laser surgery. I don't blame him. Less invasive, safer, and faster recovery. As you get older, these things seem to matter to people, right? People don't want a long recovery surgery. All right, you can see we have 2 discs below the fusion and 1 disc above that we need to fix. So I'm going to start by getting into the lower discs, and then I'll work my way up to the C3-4. All right. If you have questions, feel free to ask. But in the meantime, let's share with the audience how it is that a disc problem can become so symptomatic and painful. Shot? Shot?
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Oh, looks good. Welcome back. We have been successful at getting into this bottom disc, 6-7, which is the hardest to get into by far. And you can see the needle right there is right at the disc. Again, there's a lot of, he has a short neck, unfortunately, shot. So, all right, let's get an AP and see where we are. If you have questions, feel free to ask. In the meantime, let's show the audience how we can repair a disc herniation using a scope and a laser.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
welcome back. You can see from our video that we use a scope to get to the back of the disc where the herniation is. This is catching on my arm. And we then use a laser to remove the hernia. Let go. We use a laser to, no, don't do that. To move that. That's all you got to do. To remove the herniation and clean the tear. We are in at 6-7. Shot. All right, so here's what I'm going to do. We're going to be able to fix two discs, 5-6, 6-7, below his fusion with this incision. But I've got to make another incision further up in order to get to 3-4. So, Luis, I want you to hold this. Don't let it get away from us. And I'm going to try to get in up higher. How are we on twitches?
I just checked 0. I'll check again. You want it short?
Needle, short.
I have no twitches.
Shot? All right, yeah. That's going to be tough to get up there. He's got a pretty calcified larynx.
Hold on, ready?
No, hold on. I'm just going to have to get to that later.
Okay.
So let's just go ahead and proceed with the bottom two discs. And then I'm going to have to get everything out and try to get that 3-4 because his larynx is extremely calcified. It's hard to mobilize and move over, which I'm going to have to do. It doesn't even look calcified on the x-ray, but it is. All right, at this point, we're going to make our incision and we're going to repair this 6-7 disc, then we'll move up to 5-6. If you have questions, feel free to ask me by typing them up. In the meantime, if there are no questions, Henry, we've already shown the audience how a herniated disc can become so painful and symptomatic, but also how we repair that with a laser. Why don't we show the audience the 30 different things that do cause neck pain, because there are 30 causes of neck pain. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. That's it. We have just placed our tube into the C6-7 disc, and once again, this patient had a fusion. He now has adjacent segment disease. The discs above and below are torn and herniated and degenerated because he's basically left the herniations for a long time. Over many years, this inflammation happening in the back wall of the disc causes the entire disc to degenerate and collapse. So if you have a herniation, annular tear, herniation, best to get it fixed with our laser procedure before you get a degenerative disc. Because once you collapse the disc, there's no way to put the disc back. It's permanent. So you can get rid of the pain when you have a degenerated disc. We can get rid of the neck pain, the headaches, the cervical brachial pain, the cervical radiculopathy, cervical myelopathy, but we cannot restore the normal disc height. And even though that's just an aesthetic thing, it's still good to prevent it from collapsing over time. Any questions from our audience?
At this moment, no current questions.
All right, we're going to be in the back of this disc. We're going to see a lot of inflammation. I'm going to sharpen the picture because it's a little blurry. All right, we got our laser on. All right. So we've shown our audience now how a herniated disc can be painful. We've shown our audience how we use the Duke laser disc repair to go in to the back of the disc where the herniation actually is and do what's called a herniectomy. You guys see this right here?
Yes,
This
we do.
is the back of the disc. Beautiful. And look at all this calcified garbage. This is herniation coming up right here. So we've basically created we drilled down to where the herniation is, and we've created a tunnel for the herniation to come back and get rid of it. So that's the tube, obviously, tubular retractor. This is all herniation, all that stuff coming out right there. You guys see it floating out? So we've given it, the herniation, a way to get out. Right now it's pushing up against the spinal cord. And now oh yes, it's lifting off. We did a discogram earlier. We injected a little dye. Anyway, so far so good. We still have to get up to the 3-4 disc. That's going to be a tough one because he's got a very stiff larynx, thyroid cartilage, I should say, and I'm having a hard time mobilizing it. Anyway, look at all these pieces of herniation coming out.
We can see.
All right, any questions?
At this moment, no current questions.
All right, you streaming on Facebook, YouTube, Twitter, X?
Yep. LinkedIn, all of it.
All right.
So
Flip it.
in the meantime, until questions come out, why don't we show the audience of how it is the Duke laser disc repair is compared to all the other invasive neck
I think it's a
treatments.
great idea. Thanks, Henry.
Of course.
I'm Dr. Aro Dugmajian, CEO and founder of the Duke Spine Institute. I'm here to talk to you today about neck pain and its common treatments. Neck pain has different causes. The most common cause of neck pain is a herniated disc. Herniated discs account for about 85% of chronic neck pain. The second most common cause of neck pain that's chronic is the facet joints. There are facet joints on both sides of the spine, left and right. There is one facet joint for every disc. Facet joint pain requires a different kind of treatment targeted at the facet joint itself. For disc pain, which accounts for 85% of neck pain, the best treatment in the world is the Duke laser disc repair. It is the most advanced treatment that is the safest and has the highest chance of successfully eliminating symptoms. Let's talk for a moment about what's important for patients who are considering treatment for neck pain coming from an injured or damaged disc in their spine. The most important thing for patients, number one, is getting rid of their symptoms. The type of symptoms that disc herniations or disc injuries can cause include neck pain, headaches, and symptoms down the arm, such as weakness, numbness, tingling, or even pain shooting from the neck down into the arm. The symptoms of neck pain include disc herniations, which are the most common cause, and patients want those symptoms gone. That is their number one priority and goal. The second most important goal for most patients is to avoid a complication from the treatment. Medical treatments do have complications, and the more invasive the treatment, the more likely a complication will occur. Complications from surgery, for example, can include blood clots, pneumonia, heart attack, infection, failure of the spine to heal properly after surgery. There can be implant migration or implant failure, adjacent segment disease, and vascular complications such as injury to the blood vessels or nerves in the neck, including the trachea and esophagus. Nobody wants a complication from spine surgery on their neck, so less invasive is typically going to be a better option to avoid those complications. The third thing patients really want when they're looking at treatment options for curing their neck pain is they want a quick recovery. People want to get back to a normal life as quickly as possible. They want to go back to their activities, they want to be active, they want to play sports, and they want to go back to work. And finally, the next thing to consider is long-term results. For example, if you have a treatment today and it works, how long will that treatment last, and will it create additional problems down the road for you? Treatments like spinal fusion that are invasive typically result in the need for additional treatments such as pain management, physical therapy, and possibly additional surgery. We're going to look at each of these individually and go through each of these options individually. So we're going to start with more invasive treatments that are typically recommended for patients with herniated discs or degenerated discs in their neck. The most common treatment recommended around the world is anterior cervical discectomy and fusion. That is a surgical treatment where the entire disc is removed surgically through a large incision that is very risky. There's bleeding associated and risk of injury to surrounding structures such as the esophagus, trachea, and blood vessels in your neck. Complications are very common with this type of surgery. The complication rate is accepted at 48%, which is a very high number. So if you're considering ACDF or anterior cervical decompression and fusion, you are looking at a very high complication rate. The success rate of this surgery at eliminating neck pain is very low. It's somewhere on the order of 25%. That is the generally accepted success rate at eliminating neck pain. An additional treatment that you can consider is artificial discs. Artificial discs are very similar to ACDF. The difference is instead of fusing two bones together with a metal plate and a cage, we're actually putting in a mobile disc made out of metal and plastic that moves. The problem with the movement is that these discs do pop out of the disc space. Over time, they can fail. They can cause collapse of the vertebral body above and below through fracturing, especially in patients with weak bones such as osteopenia or osteoporosis. Those types of patients are at high risk for complications from both ACDF and artificial discs. Another complication from artificial discs is that you can develop facet joint pain and adjacent segment disease, very common with artificial discs and fusion, and they typically have the same rate of adjacent segment disease. There's also a long recovery associated with both ACDF and artificial discs. Recovery can take months to years, if recovery even happens at all. There's tremendous scarring in the wound associated with ACDF and artificial discs, lots of scar tissue, lots of pain, and lots of problems after these surgeries that are invasive. Alternative treatment would be to go in the back of the neck and do a cervical laminectomy and fusion. Again, large incision, high chance of complications, very long recovery, taking years to recover. All three of these types of surgeries, ACDF, artificial discs, and posterior cervical laminectomy and fusion, require the use of postoperative narcotic painkillers. Narcotic painkillers are opioids. They are dangerous. People get addicted to them, they can be abused, and people can overdose. It's easy to overdose on narcotics because you want to keep taking them to treat the severe pain you're going to have after these invasive type surgeries. The severe pain can last weeks or even months, and the addiction can happen very quickly. Let's move into less invasive treatments such as epidural steroid injections. This is a treatment commonly recommended by pain management doctors. They stick a needle into your spine and inject the steroid medicine to reduce inflammation. While this treatment can be effective at temporarily giving you relief for a few days or even a few weeks, the pain always comes back from a herniated disc because the source of pain is never being treated. The annular tear and inflammation within the annular tear is not treated by an epidural steroid injection. The steroid goes throughout your body and causes systemic side effects such as high blood pressure, elevated blood sugar. In patients with diabetes, this could put your sugar up into the 300s and 400s, which is very dangerous for patients. So steroids should be avoided as much as possible. Next, let's turn to spinal cord stimulators. The problem with spinal cord stimulators is they are highly invasive and they are frequently put into patients by untrained doctors who are not surgeons. These doctors are typically pain management specialists, and they're putting these stimulators in patients not because they can cure your pain, but because it's another treatment that they have up their sleeves. These treatments with stimulators pay these doctors obscene amounts of money. The profit for the doctor can be in the tens of thousands of dollars. Avoid spinal cord stimulators. They do not work. They're dangerous. They put you at tremendous risk, and in the end, basically you're taking this device, sticking it on top of your spinal cord and putting a pacemaker under your skin that you're going to have to live with for the rest of your life. They cause scar tissue and they frequently migrate and get out of position. Next, we're going to talk about physical therapy. While physical therapy has many benefits, such as keeping you toned and fit while you're struggling through the pain and trying to stay mobile, but physical therapy will never, ever cure pain in the neck from a herniated disc. It will just try to keep you active and from getting more and more sedentary and developing deconditioning of your muscles because you're sitting around because you have neck pain all the time. Finally, let's talk about the Duke laser disc repair. The Duke laser disc repair is the solution for neck pain. If you have a herniated, bulging disc, extruded, ruptured disc, protruded disc, or degenerated disc, the Duke laser disc repair works by minimally invasive treatment going to the back of the disc where the problem is coming from. This is the tear in the back of the disc that has inflammation, and using a laser that is extremely precise. The laser fiber itself is 0.5 millimeter or half a millimeter wide, and the endoscope allows me to see 1/20th of a millimeter. I can directly see the nerves and spinal cord. It is an extremely safe treatment. As far as results go, the Duke laser disc repair has the highest success rate of all the treatments we've discussed so far. We have a 99% cure rate of neck pain coming from herniated discs, and the Duke laser disc repair has 0 surgical complications to date. Our patients have an immediate recovery. In 1 hour, they're leaving our facility and they're going back to their hotel room. They usually drive themselves in the next morning for a quick checkup, and then it's back to a normal life. Well, I've enjoyed talking to you, and thanks for taking the time to listen to our video. I'm Dr. Ara Duke-Majan. We'll also find this on our podcast at Duke Spine Institute Podcast. Thank you. On for a little while, we shared with you our video comparing the cervical Duke laser disc repair that we're doing right now compared to other types of treatment that are offered to patients who have neck pain or disc herniations. And you can see that those treatments either are highly invasive and don't fix the neck pain, or they give temporary relief for a few days or weeks, such as steroid shots can do for neck pain, like an epidural steroid injection, series of 3. But then the pain comes back. And why is it? Because none of the treatments that you saw in that video, except for the Duke laser disc repair, actually treat the source of symptoms from a herniated disc. Now, fusion will remove the herniated disc and the symptoms, but then you've got all kinds of side effects like scar tissue, difficulty swallowing, difficulty breathing, change in your voice, all those negative things. All right, we're going to move out of 6-7. We're going to move up to 5-6. You guys ready? Is that our picture, Jordan? Yeah. All right, here we go. If you have questions, I know there are some questions. Type them up. I'm going to answer them. By the way, I want to show you the incision is only 4 millimeters. 4 millimeters. We're going to fix 2 discs with one 4 millimeter incision. There's no metal here with the Duke laser disc repair. This is endoscopic surgery, and it is done without any kind of fusion or metal. It's all natural. All we're doing is going in and removing the herniation along with the a lot of the bone spurs that are there that are pushing on the nerves. We're removing the herniation. We're cleaning the tear in the back of the disc so that the tear will heal itself. And your body will definitely heal the disc and seal that tear after I clean it out. All right, we're outside. Now I got to make my way up to the next disc, number 5-6. That's the one right below his fusion. Shot? Need an AP. Give me a second. Type your questions. I'm not going to take questions right now. This is the hardest part of the surgery, in my opinion. So I'm just going to focus on it. You can see the tip. Show them the tip is in the middle of the cervical spine. You can see the spinous process on the back side of the vertebrae. We're dead center, so that's perfect. Show them the endotracheal tube. You guys see this black line? No, that's the esophageal temperature. So that's the endotracheal tube right there. And the braided line is the esophageal temperature probe. So we got two things, one in the esophagus, one in the trachea. The trachea is going to be the endotracheal tube. All right, I'm going to move up to the next level, hopefully. Let's see if I can do that. He's got a lot of bone spurs, a lot of scar tissue shot. All right, he's got a huge bone spur here right at the mouth of his spine. Shot like a fish mouth. You guys see it? It's like a giant fish mouth or parrot beak.
Yes, we do.
Here we go. Going up the mountain, and here we are. We're up the mountain. We're right in the middle. There it is. Perfect. Show them, Jordan. Give me an AP. Yep. Guys, see that little bone spur in the front of the spine? So I'm sitting right over the disc. Nobody move. Nobody move. AP shot. Perfect. We're just a little to his right. I'm going to correct that. Stay there. I'm going to correct that. I'm going to move back to his left just a little bit. I want to be dead center as much as possible. Shot. There we go. All right, we're perfect in the middle. Lateral view. Going back to a lateral view. So we're getting into the next disc. Not yet. Yep, there it goes. I felt it. You guys see that? Show us the disc, Jordans, for the audience. The number 5-6 disc is right there. We're heading inside. You see the tip of the dilator? Here we go.
Yes, we do.
Now, the good news is, as you hammer this in, it slides in nicely because the disc is soft. It is what we call the path of, Jordan shot, the path of least resistance. And the path of least resistance is a special physical principle that basically means things tend to go towards the path of least resistance. In other words, if there's a wall and you're trying to go on the other side of the wall, you find a door, and that door is the path of least resistance. Unless you're the juggernaut. Shot. All right, here we go. Shot. Anybody see Deadpool 2?
Yes.
I love that guy, Ryan.
Reynolds.
Yep. Great actor. My mom and I were talking on the way to work this morning. She just watched The Hitman's Bodyguard. Shot. Okay, you can see we're heading towards the back of this disc. There, show us the tip, Jordan. All right, a little inline traction. We're getting to the back of the disc. I can feel it compressing. There we go. Perfect. I'm going to put, let me just show the audience. You guys see this tube? This is the whole surgery is done through this tube. It's just 4 millimeters wide. Now, every spine surgeon in the world would be doing this exact surgery if they knew how to do it. Period. If they could do this surgery, they would do it. They don't have the equipment. They don't have the training. They don't have the staff. They don't have any of that. It took me a long time to learn how to do this surgery. And I was lucky. I got trained by the Koreans many years ago by the original, the OG, the original gangster neurosurgeon, Dr. Sang-Ho Lee himself. He's the one who pioneered this technique. Brilliant man, neurosurgeon from South Korea, founder of the Woodidal hospital system in Korea. People from all over Asia travel to the Woodidal hospitals. Some of them are even in airports. That guy did it right. He's a gazillionaire and retired. Has nothing to worry about. Has like 8 or 9 or 10 hospitals now. Me, I struggle every day to make ends meet here at our company and pay our staff, keep the doors open and treat patients. All right, I think I need to advance the dilator just a little bit. Anyway, I took what Dr. Sang-Ho Lee taught me and it made it better, improved on it. Go ahead. And I added the laser, I added the annular debridement. So, and I published it many years ago. Shot. All right, looks really good right there. So, that's how medicine is. You take technology and somebody makes it a little better. Let's talk about radiation, for example. We used to radiate tumors of the head and neck with direct radiation. And what happened was you zapped the tumor, but it didn't penetrate well enough, but it burned the skin. So early, 100 years ago when they were treating tumors on the head with radiation, they would cause all these side effects of burnt skin and holes in the skin, and the jaw would melt, the bones would melt because they got such high dose radiation. Then somebody came along, and Lars Lexell, and figured out, well, radiation is additive, so if you shoot a beam here that's low dose, it won't hurt the skin or the bone, and then you shoot another beam from the other side, and if they cross in the middle where the brain tumor is, they would add up where the brain tumor is where they cross, but they will not provide much radiation to the normal tissues that they pass through. So Lexell created this Lexell radio surgery machine that basically shot beams of radiation that passed through the body, not harming anything, not the tissue, not the muscle, not blood vessels, not the bone, but they met in one spot, and that spot happened to be where the tumor is. So he would aim them to the tumor, and they would add up at the tumor and kill the tumor, but not harm anything. So that was a technological advancement. He took a known entity, radiation, that was being used in medicine, and he modified how it's used and created a much better way of treating tumors, and we use that today. So I took a technology that I was taught, endoscopic surgery of the spine, and I modified it and added in the laser and added in the debridement. And doing such, I was able to change the results of the surgery and make it far better for patients, because I can cure their neck pain, their cervical brachial pain, their radiculopathy, their myelopathy. Yeah, it's completely different. All right, we're inside 5-6. We're just below the fusion. Now you can see all the herniation here in the crack at the back of the disc. And I'm going to keep working here while you guys ask questions. I'll answer your questions. Go ahead, Henry.
This first two questions are coming from Gary on YouTube.
Hi, Gary. Welcome.
First question saying, morning.
Morning.
What causes the disc to calcify, and is it hard to remove the herniated part? Keep up the awesome work, doctor.
Yeah. Hey, great question, Gary. So, Gary, very interesting question. What causes the disc to calcify? What causes the disc to calcify is a process called dystrophic calcification. Dystrophic, spelled D-Y-S-T-R-O-P-H-I-C, calcification, dystrophic calcification. Please look it up. I learned about dystrophic calcification first in medical school in pathology. Pathology is the class in med school where doctors learn about diseases. Pathology is the most important medical school class you'll ever take. It teaches doctors about diseases. What's the basis of all disease? It turns out that dystrophic calcification occurs when there's chronic inflammation. So when tissues are getting inflamed for a long, long time, then the inflammation comes in where your body's attacking and causing damage, and then as the tissues are damaged by your inflammatory system, they start to calcify if it's been going on for a long time. So your body lays down calcium that's normally found in your bloodstream, circulating. But remember, inflammation is an inflammatory process. So to have inflammation, you must have circulation in the area of the inflammation. Your inflammatory system uses the circulatory system or your blood vessels to travel around your body and to get to tissues, right? So we don't have typically inflammation in the brain because we can't, the inflammatory mediators can't cross the blood-brain barrier. But if there's something like a bacterial infection where in your brain where the bacteria are eating through the blood vessels, now the blood vessels leak and the inflammatory system can get to the infection and attack it. So for the inflammatory system to get anywhere in your body and fight the invaders, it must have a transportation system to get there. Now, think about war. If you're going to, fight a war and you're going to use ground tactics, you're going to need tanks, you're going to need transport vehicles to transport soldiers. You need highways, you need roads, bridges, right? So all these structures on the ground to allow the troops to get to where they need to go. But if you have air, like, an Air Force, then you can transport troops and goods through air, but they have to still distribute once they get to the ground. So no matter what, you need a transportation system to allow your troops to get around the battlefield or get to the battlefield or get to places where they prepare for battle. The point is you need transportation system. In the human body, the inflammatory system, which is our military, it's like the army, it uses the circulatory system to get around, okay? And sometimes the lymphatic system. Point is, you need to understand that the circulatory system or blood system that transports cells and nutrients and glucose and salts and calcium is needed to have calcification of the disc. So it's calcium in your blood system that comes from your bone, by the way. Your bone gets dissolved, releases calcium phosphate. The calcium travels through your circulatory system and makes its way over to where the inflammation has been going on for a long time, and it somehow attaches itself to the dead tissues that are here, right here. This is all calcium that I'm zapping away right here. You see the laser hitting this? That's a bone spur. That's dystrophic calcification, okay? So it's abnormal calcification that occurs in the human body as a result of pathology and chronic inflammation, basically. Hope that explains it. By the way, that's the spinal cord down there. You guys see that? And I'm basically zapping a bone spur right off the front of the spinal cord. So, any other questions?
Yes. Next question from Gary on YouTube asking, also wondering your opinion as to would there ever be a point when a fusion would be on the table for you as an option?
Well, a fusion, great question. So what Gary's saying is when would you consider like a fusion of the spine? The answer is I consider it on every patient. I give my patients the option. I say you can have the laser or you can have a fusion. Both surgeries work if done properly, and the patients don't want fusion. They're not stupid. Fusion is an older technology. I used to do them all the time. I've done over 1,000 cervical, just in the neck, fusions in my career. And that's fusions and artificial discs combined, mostly fusions. So I've done a lot of them. And for a fusion, it's far more invasive, destructive, more risk of complications, no matter who's doing it. And you're having metal put in your neck usually. You're fusing joints that shouldn't be fused. It's just a very unnatural thing. Now, the only reason we do a fusion is this is it. You see this down here? That's where the herniation is, down there, okay? It's pushing on his nerves and spinal cord. Every surgeon wants to get rid of this, but half of them do these fusions without ever getting rid of this because they never make it down this far. This is really deep, and most of them don't have the skill or the equipment or training to do this. So all they do is just take front of the disc out and fuse the joint. Okay, hoping that the patient doesn't get worse. Well, people don't want to not get worse. They want to get better. So to make them better, you got to actually go down here and remove the herniation. You understand? Which is what I'm doing right now. That's what I'm doing with the laser. So the laser allows us to get down here, remove the herniation without taking the disc out. See, once you take the whole disc out, now you got a space in there. You got to put something in it. And that's when surgeons put a cage. That's your fusion right there. So the only reason you need to do a fusion, truly, is if you take the disc out to get to the herniation in the back. Make sense? That's how fusion started. The surgeons were taking the whole disc out to get to the part in the back using a microscope to see the herniation after they took the whole disc out. But since we use an endoscope, we go through the disc, we don't take it out, we don't need to do a fusion. And that was the brilliance of Dr. Seng-Ho Lee, right? He's the one who figured out, why don't we just stick a scope through the disc to the back where the herniation is, remove the herniation. But he didn't use a laser, he used grabbers. And so I modified his technique and I brought in the laser and grabbers, both, but mostly laser. And I realized when I cleaned the tear right here, not just remove the herniation, but clean the tear, I actually got rid of people's neck pain. I mean, literally got rid of it permanently. So that's when I realized this is a surgery that doesn't just unpinch nerves and get rid of arm symptoms like radiculopathy, but I also get rid of, and not just unpinched spinal cord, get rid of myelopathy. That's all calcium right there. You see the gold stuff? That's the dystrophic calcification I've been talking about. It's calcifying the scar tissue. It's calcifying the annular fibers that are torn and inflamed. And it's laid down here as your body is basically trying to burn out the inflammation. Basically bring the military home to its family, stop the war. So for some reason your body lays down this calcium right there. It turns an orange color when it's hit by the laser. I love the military analogy. I use it for a reason. It's probably the best way. It's the best way to understand your inflammatory system, which is basically a division of your military. It fights off invaders. All right, any other questions?
Yes, this next one comes from FLA Day 392 on YouTube,
15 minutes.
asking, wow, that many levels and don't have instability?
Yeah, great question. So what is instability? Anybody know? You guys all throw the word around like you really know what it means. But 99% of people don't know what instability means. Neither does 99% of doctors. They have no clue what instability means. See, spinal instability was first defined by doctors White and doctors Punjabi. White and Punjabi wrote a paper back in the, I think it was the 80s, 70s or 80s, where they defined spinal instability for the first time ever. And they were right. Spinal instability is when a patient has severe debilitating pain or neurological deficit, which is weakness, numbness, tingling, or paralysis, with normal physiological loads to the spine. What does that mean? It means that just normal walking, normal lifting, normal work, not like lifting heavy things, just normal stuff that like a 7-year-old woman would do, okay? With normal physiological loads or weights to the spine and movements, patient develops horrific pain and neurological deficit. Do you understand? That's what instability is. Now, that definition was changed over the years by the insurance industry because the insurance companies don't want to pay, because the number of patients with pain in the neck, pain in the back, neurological symptoms down their arms or legs, or myelopathy, the number of patients with this condition is huge, millions of people in America and the world. The insurance companies said, oh, shoot, we don't want to pay for millions of people that have spine surgery, so let's create a new definition of instability, and let's make it when you see the bones slipping on each other, okay? We'll call it spondylolisthesis, which has been around for a long time. Spondylolisthesis is not instability. The insurance companies can't just define what they want to be instability. And then they say, oh, we're only going to pay for spine surgery when you see instability, bones slipping on each other, okay? And everyone just laps it up like a stupid dog. Oh, the insurance company said that. Well, they of course, they don't say it. They hire doctors to say it, right? So, oh, the doctor said it. So basically, we're a bunch of fools allowing the insurance industry to basically not pay for surgery that we need for real instability, which is pain and neurological deficit with normal physiological load, and redefine the word instability and define it the way they want it so that almost nobody has it, so they don't have to pay for surgery. That's what's happened over the last 15, 20 years, okay? So go look it up. White and Punjabi, spinal instability, they defined it first, and it's severe pain in your back or neck or the development of neurological deficit with normal physiological loads, okay? That's it. So don't come in with some alternative definition of instability. I don't accept it, okay? I don't accept it. I accept the truth. The truth is, Luis is gonna, I don't know what you're doing. We're okay. Relax. I'm just holding pressure for a minute. There should be no bleeding, maybe a little vein bleeding. But we're done with the first 2 discs. I'm gonna now try to get up to number 3-4 above the fusion. That's gonna be tough because remember, he's got this calcified voice box that's like, I can feel it, the thyroid cartilage, right? Any other questions?
No current questions, but we do have a comment coming from one of our viewers on YouTube saying, I was a patient of yours in 2023 with a T8, T9 done and completely took the pain away in that spot and that I have suffered with for 23 years. May God bless you and your amazing, sweet team.
Thank you so much. We need God's blessing, folks. I'll tell you why. We struggle financially at Duke Spine to stay in business, and the only money we get is from patients. The insurance companies, we've been fighting them for years. It's so hard to get any money from them, and they basically don't want to pay for people's medical care. So there's not a month that goes by that we don't have to worry about our overhead. All right, but thank you. I'm glad you're doing well. All right, shot. So I'm going to try to get up there. Let's see what I can do. Shot. Yeah, that's tough. AP, quick. So I'm way below the disc, but there's so much scar tissue from his prior surgery that it's making it super difficult for me to get there. Good. That's it. But I can't mobilize the voice box. And what I'm going to do is I'm just going to go down right here, and I'm going to move up. So it's a technique I developed. It's called the Duke Spine Shuffle. And nobody taught it. I had to figure it out myself. But it's my desire and drive and passion to help people like this patient. And basically, if I don't fix that other disc because I can't get there, he loses out. And I don't want him to lose out and not have the surgery that we set out to do. I need a little local. And this is something that I pioneered, and I don't think there's anyone else in the world that does this particular move. All right? So let's hope it goes well for him. This is spine surgery after all, and lots of bad things can happen. So I pray to God nothing does.
Good vital signs.
Yeah, thank you. Patient's stable, good vital signs. So remember, I've got to get to the disc. Show them, Jordan, on the x-ray. I've got to get to right where the arrow is. You guys see the white arrow, Henry?
Yes, we do.
I got to get there. But look where I am. I can't get higher with my fingers pushing because everything is so stiff and scarred from his prior fusion. So now I'm going to use my dilator, which I know is rigid, right? It's hard, and I can get it down to the spot, and then I can slide it up, all right? So that's what I'm going to try to do. Let me have it. Any questions?
Yes, we have a question from Charlie on YouTube
Hi, Charlie. Welcome
saying,
to our live stream.
saying the Jefferson Lehigh Valley Hospital Network announced they will be dropping United Healthcare insurance. Do you envision more of this happening?
Yeah, great question. So one of our viewers, Shot, mentioned that the hospital system is dropping an insurance company, United Healthcare. That happens all the time, my friend. It happens every year. It's been happening more frequently over the last 5 years. It's happening because the insurance companies are so unbelievably greedy that they just want to take the money that you pay them in premiums and not pay the hospitals or doctors, okay? So this, we're dropping the insurance situation really comes about because the insurance company, United Healthcare, is asking the hospital to take a cut in the amount of money it's getting, all right? And what's happening is the hospital is saying, hell no, we can't afford it. We're going to go out of business. And a lot of people don't realize that hospitals' profit margins are only about 2%. So if a hospital brings in $1 billion a year, which most don't, by the way, they bring in a couple $100 million. If a hospital system brings in, let's just say $100 million a year, then that means their profit margin usually, if they're managed okay, is around 2%. Okay? Now they have other investments, so they put their money in stocks and things like that to make money because they sure as shit don't make it from insurance companies. They keep getting, their legs cut off from the insurance industry. I've seen these negotiations happen. I was the chief of staff at my hospital, and we dropped Blue Cross Blue Shield. But then 3 months later, they re-signed the contract. So it's kind of a stall tactic, kind of like what's happening in Congress right now, where two sides are fighting each other. But I'm going to tell you right now, the bad guys are the insurance industry. They always have been. And they're so greedy. And I'm going to tell you why. Of every dollar you pay them, the government, Obamacare, mandated that they're supposed to spend 85% of that dollar, 85 cents, on you, the patients, right? Or administrative duties, basically managing your benefits. They are not doing that. They are basically taking that money and they're spending it on profits. But they hide the profits in what are called subsidiary companies. So they'll have the owners, the big, I hate to say it, but the rich old white guys that started United Healthcare, probably somewhere in England, some financiers or banks, these guys that own the insurance company basically are bilking out money. They're sneaking it out of our country in the form of janitorial services. That's the one I like to use the most. So United Healthcare, for example, has a building in, Houston, and it probably really costs $10,000 a month to clean that building. But they own the rich old white guys and bankers that own and started United Healthcare. They have a janitorial company called Janitors R Us, and that janitorial company charges $10 billion to do $10,000 worth of work. And that $10 billion goes to their janitorial services company overseas, so it's hidden from our government because it goes to a foreign company and it's not regulated by our government. The government doesn't see that profits. So that's how they're sneaking the money out that should be going to patient care, and they're stealing it right out of our economy. Now, how do I know this? Because I was the president of the Medical Society, and Blue Cross Blue Shield, for example, I've done a lot of research on this stuff, so I know it from many sources, but one of the sources was my own experience with Blue Cross Blue Shield, where basically they came in and said, we got a great plan for all the doctors here in your county. We want your doctors, all the doctors and their staff that work for them in their offices to sign up with this Blue Cross plan. It's so good, and all the money really goes to you guys and paying for your care, right? Very little goes to administration. So I wasn't stupid. I don't just believe people because they tell me something. I said, oh, well, what was the premium paid by the other medical society? Oh, it was $14 million a year. Okay, great. Then the next time I saw this joker, I said, why don't you come back next month and talk to us again? So when he came back the next month, I said to him, so that medical society, how much did you guys pay out on claims? What was your medical loss? And he said, $6 million. Well, if you do the math, they paid $14 million for premiums, right? And they got $6 million in benefits. That means $8 million is profit. All right, and that's a good plan that's supposed to be 85% going to the patients. They're liars. They're horrible, horrible liars, and they're destroying our healthcare system, and nobody is catching them. And I wish to God Trump would pull his head out of his ass and address the biggest killer in the world, which is the health insurance industry in America. Oh, their margins are ridiculous, yeah. They make money in the Medicare Advantage plans, ripping off the government, taxpayers. They don't pay. And they get incentivized to not pay. They get bonuses from employers under the ERISA plans when they don't pay claims. If they have an employee for like McDonald's who needs a cancer surgery and they deny the surgery and it's a $100,000 surgery, Blue Cross gets to keep 20% of that. So they keep $20,000 for denying a $100,000 claim. Then they go back to the employer and say, look, we saved you, $100,000, but they get their $20,000 for doing nothing but denying the claim. So the insurance companies are out of control. Also in pharmacy, you guys have heard this, not just from me, but from other people. When you go to the pharmacy, you pay $20 for your prescription. The pharmacy then pays off the insurance company for sending you there. $10. It's crazy what's happening. And again, you guys just need to know about it so you can do something about it if you care about your health. All right. Anyway, meanwhile, doctors like me that pioneer revolutionary technology that cures people of a disease that's the most common disease in the world, back pain, neck pain, we get put under the rug and they try to put us out of business. Yeah, in line. They haven't paid our claims. They pay zero. We have tons of patients coming with insurance. They deny paying for the surgery. They say we're not going to pay, or they say we'll pay and then we do the surgery and then they don't pay. And we're stuck just accepting what we got from the patients unless we sue them. And suing them takes millions of dollars, which, by the way, we are doing with the help of our patients. Unfortunately, one of our patients took the surgery for free, didn't pay a deposit, and just disappeared. And apparently he got fired from his job, never took COBRA, so now we can't even sue to get paid. It's just unfortunate situation. All right, any other questions?
No current questions, so we do have a comment from Carlos on YouTube saying, great information.
Yeah, you're welcome. Nobody else will tell you the truth. Mostly because doctors don't understand insurance at all. They just go to work and hope that they make enough money. But doctors are starting to become more savvy. Patients are getting savvy too, because they're the ones getting screwed by the insurance when the doctors don't get paid, hospital doesn't get paid, and now the doctors are onto them and they won't do the surgery or treatment without a confirmation of payment. And that's why you get situations like happening with that hospital system where they drop United because let's hold off because I may not need it.
No?
Yeah, I didn't need it for the other two, right? Yeah. Let's just wait. Just have it on standby. So yeah, what happens is the hospitals get screwed, and finally somebody in the CFO, the hospital's losing money, they don't understand why. Then the CFO is just out golfing or fishing, and then they realize, holy God, we signed these contracts, right? The CFO signed these contracts where United doesn't even have to pay us, they get to deny whatever they want as experimental. Then the hospital doesn't get paid, and they're losing money, and then finally by the time they figure it out, the hospital system's almost bankrupt. Okay? But the insurance doesn't care. Look, what happens with United Healthcare if that hospital system goes bankrupt? What happens? Here's what happens. Fewer doctors in hospital for them to pay. They get to keep more money. So the insurance companies are incentivized to put hospitals out of business, because the fewer hospitals, the fewer places where they can have to pay money for doctors and treatments. That's how it is. And nobody's stopping this. I've been trying to raise the red flag for years about this. And I've been talking to you guys about it. I've been doing YouTube videos about it, but nobody's listening. You guys are listening, but nobody's doing anything, I don't think. Maybe somebody is. I shouldn't assume that. Look, when the hospital goes bankrupt, where are you going to go when you have appendicitis and you're dying? You're going to have to go to a further hospital, right? So right now there are 4,000 hospitals in America, maybe 4,200 hospitals, okay? As hospitals go bankrupt, there's fewer providers, there's less services offered to patients, and there's less bills for the insurance companies to pay. They want all doctors and hospitals to go bankrupt. That's really what they want. They just want you to pay your premium dollars, they keep it, and they never pay the hospital, okay? Because there is no hospital. That's the perfect world for them. So the more hospitals they put out of business, the more doctors they put out of business, the more profit they get to make, because they're going to keep all that money. That's the reality of the situation we're in. And it's not going to change, folks, unless you guys change it. I cannot change it. I am just one man. Just one person that nobody really cares or listens to. You guys have to fix it. All I can do is inform you. And you guys take that information and do your research and figure out the truth, and then go advocate for yourselves. Hire politicians that actually give a shit about your health. It's my advice. All right, any other questions?
Yes, we have another question from Charlie once more on YouTube.
Sure.
Saying, I've been seeing a lot of posts on social media by neurosurgeons using an endoscopic approach for spine surgery.
Yeah.
Are you optimistic for the future because of this?
Sure. Yeah, why not? Yeah, I mean, yeah. It's a complicated question. I'm optimistic if we give our patients the best treatment available in the world. What I want is every human being should have access to the best treatment. in my opinion, okay? Money shouldn't stop people from getting the best care. Period. Yeah. Well, something you guys hopefully understand, and I don't know if you do, based on the comments you're making, but there's a lot of bad neurosurgeons out there. Not bad like bad people, but there are bad people neurosurgeons too. But there's a lot of bad neurosurgeons technically that go in the operating room, operate on people, and kill people during surgery. Kill people, maim them, harm them. I am not one of them. Okay? I saw it a lot during my residency training. There were one neurosurgeon operated on the wrong side of the patient's brain to get a tumor out. And when they went in and they were looking for the tumor, they couldn't find it. And then they went back to the MRI and looked at it and they realized they were on the wrong side of the brain. Okay? That should never happen. But there's a lot of sloppy doctors out there that just don't care. And what do you think he did? You know? He didn't do anything. He just told the family, sorry, we operated on the wrong side of the brain, right? And finally we figured it out and we opened the other side up and we took as much of the tumor out as we could. But I saw another neurosurgeon who patient came in with a hemorrhage, you know, a traumatic hemorrhage, motor vehicle accident, subdural hematoma. We opened the dura. There's this big subdural, one of the easiest surgeries to do in neurosurgery. And I'm standing there watching, and he, you know, the attending didn't let me operate and just wanted to do it himself because he was tired and it was late at night and he just didn't want to be bothered with the surgery. So he just started sucking this thing out as fast as he could, the blood clot. Next thing you know, he ripped the middle cerebral artery, and then a gigantic fountain of red started squirting up. And what did he do? Well, he did the wrong thing. That's what he did, because he's a fucking spine surgeon, neurosurgeon, doing brain surgery. He took his cottonoids and put it on top and pushed down. You never do that, ever, with an arterial bleeder, because you're going to push the arterial blood at 160 millimeters of mercury right into the brain. And it's going to rip through the brain like a chopstick through soft tofu, okay? And that's what happened. And he created a massive hemorrhage in the patient's brain and killed them. He just said, oh, I'm done, got out of there and just went and told the family, had a bad result. So you guys think, oh, fucking neurosurgeons are doing endoscopic surgery. Isn't the world great? No, it's not great. What you want is the best neurosurgeons who don't make mistakes doing the best surgery for patients. And that's what you're going to get at Duke Spine Institute, but only at Duke Spine. So what you really should be happy about is, Dr. Duke, I heard that the insurance companies are now forced to pay for your surgery and that everybody in America can get it at Duke Spine. That's what you should be happy about. Oh, then I'm going to train the best neurosurgeons who actually care about patients and don't want to kill them. I'm going to teach them how to do the surgery properly so that you guys can have the best surgery in the world, right? But I don't want those kind of surgeons that kill patients to come and do my surgery or endoscopic surgery. You get excited about it, it just means more people are dying, okay? What matters is the chef, okay? You got to have the right chef cooking the right meal with the right ingredients, period. You can't just say, oh, I heard there's more steak. Who, for all you know, you're eating kangaroo meat, okay? Don't believe that every surgeon is trained the same. We're not. Don't believe every surgeon is equally capable in the operating room or outside the operating room. We're not. There are dramatic differences. And you better find good surgeons to take care of you. There's a lot of bad ones out there, and there's getting to be more and more. So, am I excited about it? I don't know. Too early to say. Let's see their results. They won't be as good as ours. I don't expect them to be. But if you do, then there's something wrong with you. Any other questions? We're almost done. I got 5 minutes. This is 3-4. A lot of bone spurs. You guys see all this stuff here? I've taken away. There's most of the herniation. I'm having trouble getting out to the foramen here, but I'm doing my best. That's all herniation stuck in the tear causing inflammation with calcification right there. Great questions, by the way. I love them. Thank you.
We have another question from
Sure.
Carlos once more on YouTube.
Of course. Happy to take you, Carlos.
Saying, I have a question, doctor. I had ACDF surgery over a year ago, and after my surgery, I experienced on my right side from my stomach back to my right foot sensitive skin to touch pins and needles and heat.
Yeah. That was immediately after your surgery? You woke up with that?
If once he answers, I'll let you know.
Yeah, if you woke up from an ACDF with a new symptom like that, that's a neurological symptom. That means your spinal cord was damaged by the surgeon during the surgery. Okay, that's not a good thing. If it happened like right away when you woke up, if you started to have pins and needles and tingling in your belly down to your leg, that means there was a spinal cord injury. Now, could it be the surgeon making a mistake? Possibly. Likely, but it could also be that you have a problem down lower and there's an artery down there called the artery of Adam Kiewicz, which is known to have sometimes what's called the dural AV fistula down in your thoracolumbar region. And if that thing clotted off, embolized, clotted off, just clotted itself off, then you could have those symptoms as well. The point is, I hope you told your surgeon, and I hope your surgeon did an investigation, like an MRI, and if they did an MRI of your cervical spine and they found that, hey, the spinal cord is normal, nothing's pushing on it, there's no T2 signal change, then that means that your symptoms are probably coming from down lower around your thoracolumbar junction, around T10, 11, 12, and you could have a thrombosed dural AV fistula of the artery of Adam Kiewicz, which you need to have investigated with a angiogram. Okay, angiogram. Any other questions?
Yes, we have one more question from Pawn Lust on YouTube.
Pawn Lust.
Asking, is transforaminal possible cervically for you or only transdiscally? How do you decide?
Yeah, Pawn Lust, I don't do transforaminal in the cervical because the only way to do transforaminal is to destroy the bones and ligaments that are normal holding your spine together. And I don't want to do that to any patient. There's no reason to do that. Transforaminal is a bad surgery. That's like saying, should I have a New York strip or should I have ground opossum meat burger? You know what an opossum is? All right, all right, so here's your question. Dr. Duke, should I do transdiscal Duke laser disc repair? That's your 20-year or 20-day aged New York strip steak. Or should I do transforaminal cervical and take all the bones and ligament and muscle out and cause a lot of problems, which is somebody ran over an opossum last night on the road and the chef picked it up and ground it up and made you a burger. Which do you want? All right, thanks for joining us. Take a look. We got 2 little cuts. They're 4 millimeters each. No bleeding. And we got it all done. Thanks, guys. Great job. And we'll be back in 30 minutes or 45 minutes for our next case. Patient with bilateral piriformis muscle tears in severe pain. We're going to go in and do the Duke piriformis release, patented procedure that I created, invented a better way to do a piriformis release. Safer, less pain, quicker recovery, higher success rate. Great job, everyone. Thanks for joining us. Let's show our audience one of our patients.
Of course.
And good morning, I'm Dr. Duke Majan at the Duke Spine Institute. I'm here with my patient who traveled to Duke Spine Institute with a couple of problems. She had neck pain from a herniated disc and facet joints, and we fixed both yesterday. She's here less than 24 hours after her surgery. She went home, back to her hotel with her family afterwards, and she came back in for a quick checkup. You can see the incision for her surgery is 4 millimeters. It's tiny. How do you feel today?
I feel good. A little sore from surgery, but that's normal. I'm so much better. I could just feel that I've been fixed, and that was not gonna happen without you.
Well, how did you hurt your neck?
I got into a motorcycle accident back in October, and it flew off the bike.
And you've been suffering since then.
Yeah.
Why did you decide to come to Duke Spine Institute?
Do you have enough time?
Sure.
I came here because I was told that I had to have this really invasive surgery. They wanted to do a discectomy.
Infusion.
Yeah, and I was very scared. I was very scared, especially after reading what could happen, the risks. It was just too much, and actually kind of scary, because when I looked into the doctor, he actually had a lawsuit against him, which the people who suggested him to me were not aware of. So I kept doing my research. I thought, well, maybe I'll just figure out how to do some exercises to help my herniated disc, which, yeah, now that I know what I know, that's not gonna help your herniated disc. Nothing is gonna put that stuff back in your disc.
That's right.
So I did 6 months of physical therapy. That was unsuccessful. I still had pain in my neck, and it was really bad. I would turn my head anyway, and I would always feel the pain right here, feel the pain in my C6. I couldn't do the things I normally did. So when I did my research, trying to look for exercises I could do to help my disc, he popped up on my feed and said, "Do you have a herniated disc? I can fix you." And the more research I did, I was just so thrilled, because nobody has his impeccable record. No one. That's why I went to him. He knows what he's doing. He is crazy confident. His staff is amazing. They're so kind. They're so attentive. The lady that did my IV was so gentle. She did it, and I was like, "You're done already?" The people here are amazing. This doctor knows what he's doing. God has his hands in his hands.
Amen. We are so thrilled that you were able to get your neck fixed here and avoid that metal plate and the fusion and the discectomy, which is totally unnecessary, by the way. I'm trying to help people understand the truth. There's no need for ACDF fusions anymore for degenerative disc conditions. We can fix it with the Duke laser disc repair and the Duke plasma rhizotomy. You can see in your video here, we went into your disc, we used the laser. We actually pulled out several big chunks of herniation. I don't know if you watched your surgery, but you could see them coming out from the back of the disc. I cleaned the back of your disc beautifully, got the foramen opened up. There was nothing in there when I was done. Now your disc is going to heal naturally without any problems. Is there anything you want to tell the rest of the world out there that you haven't already said?
If you're in any kind of back pain, any kind of neck pain, he's the only option, because he knows what he's doing. Really, he can help you. He's helped people get out of wheelchairs. He's helped people be able to ride horses again. I mean, I'm gonna be able to go back on a jet ski. I'm gonna be able to go back to my life. Obviously not right now after my healing time, but I wasn't gonna be able to have that happen before. And I'm an adventurous person. So if you're an adventurous person, if you're in pain, if you want your life back, you need to come here. You need to come here. You will never regret it. You will never look back. I promise you with all of my heart. He's the one you need to be with.
Well, congratulations on taking the faith and getting it fixed.
Thank you. Thank you so much.
You're welcome.
You've made me so happy.
You have a beautiful family. Please tell your husband I said hi. He's a very smart man.
Absolutely.
And I'm very happy you're doing well.
Thank you so much.
You're welcome. All right, take care.
You too.
Let's get you out of here.